Hello, everyone, and you're very welcome to this joint BTOG and National Lung Cancer Audit webinar this evening. Thank you very much for joining us. First of all, as always, enormous thanks to the BTOG executive team, the wonderful Gina and Dawn, for their input into this webinar and helping us set up, and also to First Sight Media for doing all of the logistics behind the scene. You'll see to the right of your viewing panel that there's an area to submit some questions. This is via a Slido, so please do put your questions or comments in there, and we've got time at the end of the webinar to address some of those. And as previously, you'll get an email for your feedback, and once you've given your feedback, you'll receive your certificate of attendance. And for those of you using your CPD diary, there's an approval code there, which will remain up for 4 weeks after today. Good. So the agenda, I'm going to take us through the findings of the State of the Nation report that were recently published. We're then going to have a talk on quality improvement by Lauren Dixon, and then Ella Barber and Adrian Cook are going to tell us about some of the innovations in reporting from the National Lung Cancer Audit before we've got some time at the end for a panel discussion. And I'm just going to ask the panel to introduce themselves to you. So starting with John.
My name's John Conabeer. I'm the oncology clinical lead for the National Lung Cancer Audit, and I work in London. Thanks for coming.
Doug.
Hi, good evening. I'm Doug West. I'm a thoracic surgeon in Bristol, and I'm the surgical clinical lead for the National Lung Cancer Audit.
And David.
Hello, I'm David Cromwell. I'm a health services researcher and provide some of the methodological input into the audit.
Lauren.
Hello everyone, my name is Lauren. I'm the clinical fellow working with the National Lung Cancer Audit, and I'm a cardiothoracic trainee.
And Ella.
Hi, my name's Ella. I'm the data scientist that works on the National Lung Cancer Audit.
Adrian.
Hello, I'm Adrian. I'm a statistician, and I also work on the lung cancer audit.
And Sarah.
Hi, I'm Sarah. I'm a methodologist on the National Lung Cancer Audit.
And Payne. Great, fantastic. So we've got the whole team here, so feel free to ask any questions of the team. I should introduce myself. So I'm Neil Navani. I'm a respiratory physician based at University College London Hospital, and I'm senior clinical lead for the National Lung Cancer Audit. So it's my pleasure to sort of share some of the results of the from the recently published State of the Nation 2025 report. Here's some disclosures. So the report is for patients diagnosed in the calendar year 2023. As other recent reports, we've used the Rapid Cancer Registration dataset as the main data source for England. For Wales, it remains the gold standard dataset that has been traditionally been provided. For the first time as well, we've got some biomarker data to share with you. And you are able now to access your trust level data and also the full report available on the NLCA website that you can see there. And we'll share a QR code, I think, later on in the presentation that you can point your phone at and download the report. So let's look at some of the headlines from the report. First thing to say is that there were 37,750 people diagnosed with lung cancer in 2023, and that represents the highest number that we've ever seen in England. And this has clearly been increasing year on year since the pandemic. Importantly, and a major headline from the report is that we now have the highest proportion being diagnosed at stage 1 and 2. So this is 37%, increase from 32% from the previous year. And proportion of patients diagnosed with stage 4 disease has also fallen down to 43%. Unfortunately, however, the proportion diagnosed via the emergency route has remained relatively static and, in my view, far too high at 31%. You can see here at the bottom that the proportion of patients diagnosed with stage 1 and 2 lung cancer has significantly improved over the last few years. And this obviously primarily is down to the value of the targeted lung health check, and now known as the lung cancer screening program. If we look at the absolute numbers, you can see that the increase in total number of diagnoses really is driven by that, by detecting more patients with early stage disease. So those with stage 4 disease has remained relatively static over that time period, whilst those with stage 1 disease and perhaps stage 2 disease as well has increased in time, over time. What's obviously really important is to know whether we are treating those patients we're diagnosing with early stage disease with curative intent. And the good news here is that the proportion being treated with curative intent has been maintained at 80%. So despite the increase in number of stage 1 and 2 disease, the proportion being treated with curative intent has stayed the same. So that's very reassuring. For our patients with stage 3A disease and good performance status, there is still perhaps a gap here where the proportion receiving curative intent remains static and relatively low at 60%. 2023 showed the highest proportion of patients that we've ever reported receiving surgery. So 20% of the entire lung cancer, non-small cell lung cancer cohort underwent surgery. So you can see a significant bump up compared to previous years. And if we look at the absolute numbers, this reflects a very clear trend where the number of surgeries has increased year on year over the last few years. We're now far exceeding those that were being done, number of surgeries that were being done prior to the pandemic. We can obviously clearly see the massive impact that the pandemic had on lung cancer surgery, but also the fact that we've now recovered, and then the impact of screening and other early detection measures, which has meant that we're now doing more lung cancer surgeries than ever before. So that's all, I think, generally very positive. However, what perhaps is not so encouraging is the proportion of patients undergoing systemic anti-cancer therapy. So this refers to the proportion of patients with advanced non-small cell lung cancer and good performance status, so PS 0 to 1, who received SACT. And that has remained static and low at 62%. Another headline is that unfortunately waiting times remain unacceptable. I think we'll probably all appreciate this in our clinical services, but the median time from referral to surgery for early stage lung cancer was 83 days, and the median time from referral to systemic therapy for advanced lung cancer was 66 days. So this is way beyond the government's guidance of 62 days and way beyond the guidance suggested by the National Optimal Lung Cancer Pathway, which suggests treatment should be started within 49 days. But what about survival? So I'm pleased to say that the survival for 2023 patients is higher than it's ever been before in England. So we've particularly looked at the first half of 2023 so that we could report a 1-year survival in particular, and that's gone up to 50%, so a significant increase compared to previous years, and the first time that we've hit a 1-year survival of 50% for our lung cancer cohort. And you can see as well that the median survival increased as well primarily being driven by the more early stage patients that we're diagnosing. This is the funnel plot of all of our at alliance level for survival, and we can see that there are no negative outliers for 1 year survival, which is good to see. On the left, we can look at the Kaplan-Meier of survival according to disease stage, as we would expect, really encouraging survival for those patients with stage 1 and 2 disease. However, our patients with stage 4 disease, which still clearly make up a significant proportion of our patients, still have, unfortunately, a very poor survival of under 25% being alive at 1 year. And in fact, when we look back over the last few years, despite many of the significant advances that have been taking place in oncology, there doesn't seem to be a significant increase yet in survival for patients with stage 4 disease, which unfortunately was 20.8% in 2020, and on this latest data from 2023 still remains at 22.8%. In Wales, we're seeing similar patterns where there is also a significant improvement in survival, 46% 1 year survival rate now reported in Wales, higher than has ever been reported previously, and a median survival, again, significantly improved to previous years. And again, with the health boards in Wales, no significant negative outliers, which is good to see. As always, a key area of improvement is data quality. And I think many of these metrics still do require improvement. Stage is obviously good at 90%, but we want that higher performance status, and stage really crucial for our case mix adjustment. So to get those as high as possible is really valuable. Those metrics are really important to be filled out by the MDT so that they can go via the COSD data set so we can receive that. And then CNS at diagnosis, again, I think there's room for improvement there in terms of data completeness, as well as the proportion of patients being seen at diagnosis. And then our data quality for smoking status is clearly not adequate at 55%. So this is obviously really important for us to understand diagnosis and treatment patterns. We do now have, as I briefly mentioned, some genomic data. This is sort of slightly out of sync from our sort of national audit reporting cycle. So the genomic data that we've received is from between 2017 and 2021, and we've specifically looked at the proportion where testing is happening in a genomic laboratory hub, and looking at the proportion who are undergoing NGS testing, and that in that period had increased, more than doubled, from 11% to 23%. And you can see the numbers there that are receiving NGS. But admittedly, this is back in 2021, and hopefully the more up-to-date data will be a little bit more reassuring. We've looked at some of the biomarkers, obviously EGFR, we've looked at there, and you can see the proportion of patients that are EGFR positive, ranging sort of between 11.6 and 13.7%. So just as a sort of a sense check, that doesn't feel too wrong. That feels about right. And then the proportion treated overall is hovering around an 80% mark. So I think there's some work for us to do here to understand this genomic data set a lot better, hopefully link it up a little bit better to the rest of the audit, and hopefully this can be an important resource for us as a lung cancer community and to improve lung cancer care going forward. So in summary, what are the key messages? Well, I think what's very clear from the latest annual report is that There is far more early stage disease being diagnosed than before, which is really encouraging to see. We've reported the best 1 year in median survival we've ever seen. And we're seeing more patients having surgery and treatment with curative intent than ever before. So these things are incredibly positive for our lung cancer patients. But clearly there's areas that need significant improvement. I think we'll all agree that our waiting times generally are not acceptable for our patients. We've seen that the number of patients with lung cancer is going up. That's only going to continue to increase. The proportion of patients receiving SACT with advanced non-small cell lung cancer in good performance status was 62%, and this is too low. We need to understand that better, and that needs to be improved. And as always, there's significant room for improvement in certain data quality items, not just staging and performance status, but also lung CNS and smoking status in particular. Great. Thanks once again to the team who did all of the hard work behind the State of the Nation report. And as promised, there's the QR code that you can point your phones at right now to just download the report, but also the dashboards, which are going to give you your individual trust level results. And I'm sure Ella and Adrian will talk about that more shortly. Thank you. So I'm now going to hand over to Lauren and Adrian to talk about quality improvement within the National Lung Cancer Audit.
Hello. So as I mentioned, I'm Lauren. I'm the clinical fellow working on the audit, and I'm going to talk on behalf of the team today about one aspect of quality improvement that we've launched recently, which is called early signal reporting. Some of you may have received a letter from us about early signal reporting, so I'm here just to talk through the process a little bit more. Recently, we have started using our quarterly reports, which is our quarterly updated dashboards at trust level. And we wanted to have a process run alongside those quarterly reports to flag to trusts if their performance on key performance indicators was excellent and well above national standards, but also if it was below that as well. So it could become a target for local quality improvement initiatives. In order to develop our process that became known as early signal reporting, we had to consider some methodological things. So we wanted most of the emphasis to be on the most recent data because we wanted to be dynamic, up to date, and help support local quality improvement. We wanted to use proportions because most of our key performance indicators use proportions of patients, and we also wanted to be able to compare trusts of different sizes. We know that smaller trusts might be more susceptible to random variation, and we wanted to try and even that out. And we also had to be careful with our considerations about small numbers because on a quarterly basis, using performance indicators that are reduced by stage and performance status, we could end up with quite small numbers and needing consensus. So we had to find a way that worked around that. And then the process itself, we wanted to use rapid cancer registration data as it is the most up-to-date data that we have. And we wanted to get back this real-time data as quickly as possible to trusts. We have to be aware that because we're using the most recent data we can possibly get our hands on, the data completeness is not always where we want it to be. And Neil just alluded, there are key parts to that we're really trying to improve on to deliver the most reliable results we can to you. And we also had to work within our resource constraints as always. But we came up with early signal reporting. We launched it in October of last year. As I mentioned, it runs alongside our quarterly reporting, and we're really looking at those trends over time. We want to see quality improvement over time. So it's useful for detecting NHS trusts where their performance has recently changed, but also those trusts that are consistently performing well above or well below national averages. We decided that the best person to contact in each trust to highlight these and to flag these was the clinical lead. So they are our key point of contact. And the aim is really to stimulate local quality improvement. These are the indicators that are used in quarterly reporting, and Ella will be talking a little bit more about these quarterly reports in the next talk, so you'll be able to see those in action. But these are also the indicators that go through our early signal reporting process, and these have been carefully selected as targets for local quality improvement. So in order to decide who will get an early signal, the data from those key indicators is used. We look at the most recent year, so that's the most recent 4 quarters worth of data, and a Z-score is calculated for each of those quarters. Different weights are applied to each of those quarters, so most weight is added to the most recent quarter, and then we take an average. If a trust flags us with a Z-score of below 5 or above 5, whether that means excellent or poor performance, then that causes us to review that particular trust. We sense check it, and then we write our letter. But I'll show you this a little bit more in action as we go through. And this is our Z-scores. So as I say, if you're above 5, you're going to get a green flag from us. You're doing something excellent. -5, then the performance is less than the national average, and we need to find out what's going on. But we're also hoping to capture people that are, or trusts that are moving through the Z-scores. So if we're doing something that's improving performance, or things are getting worse, we want to provide that early flag for trust so that it can be reversed. So let's go through an example to see how it works in real life. So if we take an example of lung cancer nurse specialists, the performance indicator here is calculated with the numerator as the number of patients with a record of contact with the CNS from the COS dataset, and the denominator is all patients in that study period with a diagnosis of lung cancer. Data quality is an issue for this particular indicator, and the data quality metric is worked out by looking at the number of patients with the completed COS-D field divided by the total number of patients in that order period with a lung cancer diagnosis. Nationally, as you've just seen from Neil's presentation, things look like they're okay, they're above 90%, but we know that data quality is not good here. So for 1/3 of patients in England, we actually just don't know if they're receiving support from a lung CNS. And if we look into that in a bit more detail, here is a funnel plot of lung cancer nurses nationally. So this is each dot is a different NHS trust in England, and then their position on this chart changes if they have the proportion of their patients being seen by a lung cancer nurse specialist, and it moves across based on the number of patients in that trust. Only 92 out of the 124 trusts reached the 90% target for contact with a lung cancer nurse specialist. So this is an area that we could target with quality improvement. And here, if we look at data quality, none of the 124 trusts reached the 90% target for data completeness. So how would this work? How do we fit into the quality improvement cycle? Well, our main method of quality improvement as an audit is audit and feedback. So alongside the quarterly reports, we focus on those indicators. We work out the Z-scores for each trust, and we highlight those with a Z-score above 5 or below 5. And then we send letters to the trusts, and that will cycle throughout the year with every quarter. So let's see some examples in action. So these are real plots saved from quarterly reporting, and as I mentioned, Ella's going to show you a little bit more about that. But this trust here, you can see, have been excellent. They are consistently having very high levels of lung cancer nurse specialist provisions. So they should end up with a green flag from us to say that things are going great. We will then draft a letter, which will be sent to the clinical lead of that trust. And what we're essentially asking them is, what can we learn from you? How are you achieving this fantastic level of CNS provision? What can we tell other people to do? On first look at this trust actually is below national average. But I think what's important to notice is that they are gradually improving. And if there are local quality improvement initiatives going on in this trust, they are working. So they should receive an improving flag. And we would then also write a letter to the clinical lead of this trust and ask them, what can we learn from you? What can we share with other trusts that might find themselves in this situation? Here, this trust has kind of been trundling along, but in the last few quarters has started to drip down. So this should flag to us as a warning, and we can again send the letter to the clinical lead here to see what we can do to reverse this. And finally, something that really is cause for review. This trust has been consistently below national average and is starting to deteriorate even further. So it's important that we flag that to them, again to the clinical lead, and ask them, how can this be improved? The next steps we want to take to improve the effectiveness of our early signal reporting is to improve the way that we're collecting feedback from trusts. So far, the trusts that we've contacted, we've had fantastic amounts of information back. We've had really good engagement from clinical leads who are really keen to share learning from their trust. So we would like to put together just a very simple performer just to get a slightly more structured response from trusts. And in that way, build a catalogue of examples. So local quality improvement initiatives that have led to improvements in our performance indicators. And so if another trust finds themselves in that situation, perhaps they can have some shared learning from a trust that's already managed to show improvement there. In the next few months, we'll also be launching our own national level quality improvement initiative. So please keep your eyes and ears open for that. And as always, we are really, really keen to hear from the clinical community your thoughts about this. So if you have any ideas, any advice for us, please get in touch because we do respond to all of the feedback that we receive, and it's incredibly helpful for us. Thank you.
Lauren, that's great. Thank you very much. There's a few questions coming in that we'll save for the end. Don't forget to keep them coming in via the box to the right of the presentations. They come straight through to a Slido that I've got open. I've also been asked to remind people viewing that they should click the complete course button below the video so that your attendance is registered. Great. So I'll now hand over to Ella, who's going to talk about some of the innovations in reporting. Thanks, Ella.
Thanks, Neil. My name's Ella. As mentioned earlier, I'm the data scientist that works on the National Lung Cancer Audit, and I'm just going to walk through how our quarterly reporting has evolved over the last year. So as mentioned, I'll start with developments in our quarterly reporting, and then I'll also provide a demonstration of our quarterly reporting dashboard. So some of the figures that Lauren shared in her presentation, you'll have an idea as to where to find those. So for those of you perhaps in the audience that might not be familiar with our quarterly reporting, I thought I'd start with an overview. So the aim of our quarterly reporting is to present performance indicators responsive to change over time, and with the aim to support NHS providers to track their progress and monitor quality improvement. The intended audience is NHS providers in England, and this is because currently we only receive data on a quarterly basis for England and not Wales at this stage, unfortunately. In terms of the content of our quarterly report, we present 3 years of data at quarterly time increments, and the analysis makes use of rapid cancer registration data. Our indicators are selected from those in our annual State of the Nation report, and that selection was informed by advice from our clinical leads, with consideration of those indicators that we felt would be responsive to short-term changes, and also ensuring that the indicators have sufficient patient numbers when we break them down at trust level and quarterly time points. In terms of the timeline and approach that we've taken to develop our quarterly reporting, the lung cancer audit actually first started quarterly reporting in July of 2023. So we're coming up for nearly 2 years of quarterly reporting. In April of last year, our format changed. So we moved away from providing our quarterly reports as a standalone Excel file and transitioned these to be provided as an online dashboard that's refreshed on a quarterly basis. Our approach has always been iterative and incremental. So as Laura mentioned, we really do welcome feedback. We keep a log of, all feedback, suggestions, criticisms that we receive, and we use that to guide changes that we make in future updates. So as I mentioned, we do have a backlog. We keep a record of all feedback received. This is reviewed on a quarterly basis, and we'll select a number of kind of features or functionalities to develop within a quarterly cycle. That then goes through various rounds of review with our project team, as well as our funders, before then being published. More specifically, in terms of our online dashboard, we have had 2 phases of development to date. One thing I wanted to touch on is, so the lung cancer audit is actually part of the National Cancer Audit Collaborating Centre, known as NatCan. And the lung cancer audit was the first to start quarterly reporting and the first to start producing quarterly reports as an online dashboard. So very much a pilot for the centre. Generally, these dashboards have been well received with positive feedback, and we've now moved into a second phase of development where these online dashboards are being rolled out across all audits within NatCan. So this slide just provides an overview of the first phase of development that has taken place for the online dashboards for the lung cancer audit over the past year. It's a timeline that shows the additional functionality and content that we've added since launching our dashboards in April of last year. So our quarterly report online dashboard was launched alongside our State of the Nation last year and provided provider level results at NHS Trust level only at this stage. In July of last year, we moved to also provide results at Cancer Alliance level, and we included a feature where users can compare trusts within the same Cancer Alliance against each other. Alongside that, we also included denominator data. So this provides an idea of the sample size or the number of patients used to calculate the indicators. And we made some improvements to methods for calculating our control limits. In October of last year, we added a patient characteristics dashboard, and we added the feature where provider level results could be compared to national level results. And at this point, so October last year, that's when we started our early signal reporting. In January of this year, we've added a feature where users can download a report containing NHS Trust specific quarterly reports. We embedded Google Analytics in our dashboards to monitor engagement, and we updated methods for how we allocate patients to NHS organisations. And finally, April of this year is our latest update, and this aligned with the publication of our State of the Nation dashboard. So this update to our dashboards included updates to the State of the Nation dashboard, a data quality dashboard, as well as the quarterly report. And this, for the first time, we've included Welsh provider level results as part of our State of the Nation dashboard. And so from here on, another point just to mention is throughout the last 12 months, we've run a number of external showcase events. And this is really just to try and raise awareness of our quarterly reports and to demonstrate these dashboards. So moving forwards to the second phase of development, as I mentioned, this started at the beginning of this year and is planned to run throughout 2025. As I mentioned, National Lung Cancer Audit is one of 10 audits that sit within NatCan. And so lessons learned from the lung cancer team have been shared with other audits within NatCan. And as of April this year, all 10 audits within NatCan have launched online dashboards for their quarterly reporting. And so with this in mind, we've set up a dashboard working group. And the aim of this is to align development across audits and also to plan and run a number of stakeholder consultation activities. So each audit has a clinical reference group and a patient and public involvement forum. So we are continually welcoming feedback from those groups. In addition, we've run a number of surveys and focus groups, which are due to take place in the second half of this year. And as ever, through this second phase of development, we really do continue to welcome user feedback, and we will plan to use that to guide changes we make in future updates. And we will be maintaining this iterative and incremental development to our dashboard. So they're very much not a static, a static design, and we really do welcome your feedback to help shape them going forwards. At this point, I just wanted to provide a demonstration of the dashboard, so I'll just move to sharing my screen. Okay, that's great. Would you be able to just give me a thumbs up if you can see that? It should be the Lung Cancer Audit webpage, home webpage. Yeah, thanks, Lauren. That's great. So I thought I'd start by just showing you how to navigate to our dashboard. So this is the homepage of the National Lung Cancer Audit website. If you go to this Data and Statistics tab here, and then at the top of the page, you should see this button which says Access the Dashboard. If you click on that, that will take you through to the homepage of our dashboard. So you should land on the homepage of our dashboard. So I guess just a bit of orientation. So there's a black panel to the left here where you'll see Home, Quarterly Report, and a number of other tabs. This is the navigation panel. And then this white section in the center is where the content's displayed. So on the homepage at the top, there's an introduction which provides an overview of the audit. And below that, you've got an overview of the dashboards that are included. For each dashboard, we set out the intended audience, the aims, the data source, and the time period. To navigate to the quarterly report results, if you first open, click on this arrow here and go to performance indicators. This is the quarterly report performance indicator dashboard. So at the top, we start with an overview, which again just reiterates the aims, intended audience, data source, and time period. Below that, you have two user-selected inputs. So the first, both are a drop-down menu. So the first allows the user to select their NHS trust of interest. And below that, you have a second drop-down where the user can select their performance indicator. Moving down to below that, you have 5 tabs here, 3 of which provide results and 2 of which provide information. So the first tab that's selected here is the NHS Trust results. And here we have a chart presenting 3 years of data for the selected indicator at that selected trust. A few features just to make you aware of. So the chart is interactive. So for example, if you wanted to find a bit more information out about a data point, specific value, you can hover over and a text box will pop up giving you the date of that time point and the value at that time point. If you have a look at the legend over here, it is interactive. So perhaps if you find this chart a bit too busy and you're not so interested in comparing about, for example, the national average, you can click on the legend and that will remove certain data series from the chart. And finally, if you have a look in the top right corner, you'll see there are a number of thumbnails up here. One feature that trusts fed back to us was the ability, that they would find useful was the ability to download copies of these charts. So if you click on this camera icon here, you'll see there is the ability to download this figure as a PNG file. Below that, we also include, so again, the same time series, but this bar chart here presents the case volume at each time point. So that gives you an idea of the number of patients used in the calculation of the indicator in the time series above. Below that, we provide a data table. So this is the same information, but in a tabular format. And again, if you have a look, there's a download button here. That allows you to download the data table, and that will be in an Excel CSV file format. If we go back up to having a look at the other tabs that are at the top here, the second tab, it's a very similar format, but it presents results aggregated at the level of the Cancer Alliance. So you'll see the similar charts followed by a data table. The third tab provides comparisons of all trusts within the same Cancer Alliance as the trust that has been selected from this drop-down up here. And finally, if we move on to the 2 information tabs, so the first, it provides information about the indicator that has been selected. So it includes definitions of the numerator and denominator. It includes some notes about how the indicator is calculated and details of risk adjustment if that's performed. It also includes information about the target, if it's applicable, and repeats the data source, time period, and how frequently this indicator is updated. And finally, if we move on to the methods information tab, this is very much a summary. And so at this point, I'd like to also just mention that we do publish a more extensive method supplement alongside our State of the Nation report. So if you were looking for further detail, that's an additional resource that we would recommend consulting. So the information here just really sets out the data we use, the metrics we report, and there are some notes on missing data, how we allocate patients to healthcare providers, and just we set out the definition of our quarterly time periods as well. If we go back to the navigation panel on the left, you'll see there's another button here for downloading a report. So here, the user can select their specific trust of interest and then generate a quarterly report. So just some key features about this report. The format is it's downloaded as an HTML file, and this is possible to view either in a web browser or in Microsoft Word. It consolidates data, so all the results and information that I've just run through in the quarterly dashboard into a single, easily shareable document. It's important to say that the contents of this report are consistent with what's in the dashboard, so there is no new information, shouldn't be any conflicting information. We hope that this just kind of provides an easy route to get all indicators at one specific trust in one file. Again, that was based on feedback that we had received. So at this point, I just wanted to show you a bit about what that downloadable report looks like. So first, I'll show you what it looks like if you open the HTML file. So this is being viewed in the Chrome browser. So if you have a look here on the left, this is an interactive contents panel. So as you scroll down, you'll see there's the introduction with some information on methods, followed by results. If you're using this on a regular basis, you may not necessarily need to kind of consult the introduction on methods every time. So you can just, using this navigation panel on the left, quickly move to the results section. So just very quickly, that's what it looks like in HTML. And if you open it in the Word document, which people may be a bit more familiar with, this is what it looks like. So similarly, you've got the introductory information, methods information outlining the data, metrics reported, some information on missing data, allocation of patients to providers, and then we move on to the results section, which you'll see the charts are familiar to what is included in the dashboard. So again, these are in a very early phase of development. So if you have reporting needs that perhaps don't align with this format, please do feed that back to us, because I think more kind of bespoke download options is something that we're developing within NatCan. So would really value your impact on your feedback to help shape those going forwards. If we go back to the dashboard, there's just a few more tabs on the left I wanted to run through. So the first, we include a contact us page. So this just provides our email address. So as I said, we really welcome your feedback. If you have comments, criticisms, suggestions, please do use this email to get in touch with us. The next tab is an updates tab. So as I mentioned, some of these dashboards are updated on a quarterly basis. So this just really captures, with each version that we release, the changes that we've implemented. And finally, there's an acknowledgements tab. So this is really just to say that this has been a team effort over the last, nearly 2 years to get the quarterly reports to this point. So this just sets out members of the NLCA project team and professional bodies and societies that we're affiliated with. So I think that's all I had to share. I'll hand back to Neil because I think we're moving on to the Q&A section. Thanks.
Brilliant, Anna. Thank you very much. Okay. So thank you very much for all of your questions and comments that have come through. So I'm just going to put some of these to the team, if I may. There's a question about some of the Welsh data. Can Wales receive feedback on a quarterly basis? Who wants to take that? Ella?
Sorry, was that about Wales being incorporated in our quarterly reports? Is that the question?
Correct, yes. Yep.
Yeah, so unfortunately the Welsh data, again, sort of Adrian or David, feel free to come in on this, but currently the Welsh data we only receive on an annual basis. And so whilst we've moved to include Welsh provider level results as part of our State of the Nation dashboard, that will only be refreshed on an annual basis because that's how frequently we receive the data currently.
Great, thank you. Lauren, there's a question for you. If we may, so are there any specific examples of successful initiatives in trusts that can be shared?
So that's a great question. We haven't had any directly from as part of the early signal reporting at the moment, but some that in kind of the exploratory work that's been done so far, there are a few examples which I think are quite interesting. So on the topic of the lung cancer nurse specialists, there was a trust that was performing quite low for data completeness. That then had an improvement. And when I asked them about this, what they decided to do about it is that they felt it wasn't a problem with lung cancer nurse provision, but it was just that the data wasn't being recorded. So they changed the clinic letters to include a box on the clinic letters that explicitly said which healthcare professionals were present at the meeting. And in that way, that data was then recorded that the patient had had a contact with a lung cancer nurse specialist, and then had and that was uploaded then to COSD, and then we knew about it and could report their fantastic data completeness for lung cancer nurse specialists. So that's just one very simple intervention that showed improvement relatively quickly, and that's sort of the basis behind our idea of the shared learning with simple, cost-effective techniques that can improve things.
That's great. But Lauren, you talked really nicely about the early signal reporting, which I think is a really important part of the audit process. It gives the audit a little bit of extra, white teeth, but it sort of means that if there are sort of results that are outside of statistical norms, then actually we have the ability to report that back to trusts and expect a response. It's not necessarily a nice thing for trusts to receive. Nobody wants to be told that they're performing badly. Can you just explain a little bit more about the process, about how trusts are informed and perhaps any support that is offered?
Yeah, of course. And I think that's a really important point, that everybody is working so hard. And so it's not pleasant to receive feedback that perhaps things aren't working out as we would all like. So if we notice this, I think that it's an early signal reporting. So it's early, it's with time to do something about it before it becomes a big problem. And that's one of the key things, that this really is an opportunity for improvement. So if that is flagged to us within the data, then we sense check it, just to make sure that it is appropriate, it makes sense in the real world. And then we email the clinical lead responsible for lung cancer in that trust, and we explain what we found. In terms of support, we send the link for the quarterly report so that the data is accessible. It can be sense checked from their side. We are working on ways to share data back to trust so that data can be checked, because sometimes, as been mentioned, we're using the most up-to-date data we have. So if we're noticing a problem, it's important that we can check that data. And then depending on the problem and depending on what we can do, we can offer different levels of support. We have quite a lot of quality improvement material on our website, and we can direct relevant sections for that. And as I mentioned, one thing that we'd really be keen to do as we build through our early signal reporting is share examples of quality improvement initiatives. And if in agreement, we could link trusts with other trusts that have previously overcome this problem, or trusts that are performing particularly well in that area, to try to do a bit of peer-to-peer support and shared learning.
That's wonderful, thank you. David, a question for you, if I may. So as has been mentioned, the NLCA now for some time has been part of NatCan. So sort of what have been the benefits there, and perhaps what's NLCA been able to learn from some of the other audits?
Yeah, thanks, Neil. So NatCan started in 2022 October, and it's been quite an activity to try and bring the existing audits, of which there were 5, alongside the new 5 audits that are in these new cancer sites with pancreatic, ovarian, etc. There's a number of things that we're trying to do. Some of them are a bit behind the scenes. For example, there's kind of checking that indicators that might be doing the same things across audits, like access to clinical nurse specialists, that they're reported and calculated in the same way. To be true, it's in fact Lung who's taken a bit of a lead in some of the work that we've been doing in NatCan. As was mentioned, the dashboards were launched first in the lung cancer audits, and we've used that experience as we developed the dashboards for the other audits, both the new and the legacy ones, so that when they were launched about 6 months ago, they looked to have this kind of similar feels and similar features. And I think that's one of the things that we're trying to do to make life easier for those staff that are working across audits, that they're used to the way in which NatCan reports the information. We're aiming to also start to bring information from other audits back to a single report. That's still very early days at the moment, but again, for those individuals who are interested not just in lung but actually interested in a number of the audits at their trust, for example, there'll be a way to kind of pick up that information. Where Lung can learn, there's issues that, for example, we developed in the breast cancer audits about how to measure frailty, and that helps us understand information about who's receiving particular treatments. We're looking about how to use that across audits. There are some other more interesting outcome indicators that, for example, the prostate cancer audit developed something to pick up toxicity from radiotherapy. Again, that's an option that we might be able to roll out across audits. So I think it's quite an exciting time, although quite a lot of it goes on in the background at the moment. But hopefully you'll see the benefits of that shortly.
That's great. Thank you, David. Really exciting to hear that there might be, work that we can do within NLCA on frailty and radiotherapy toxicity. I think they would be really valuable additions. Doug, can I bring you in at this point? Some of the data we discussed earlier showed that there's a significant increase in the number of thoracic surgeries that are taking place. I think 1,000 more in 2023 compared to the year previously. And this is only with about a 30% coverage of screening. That was back in 2023. We now have about 36%, I think, coverage of screening nationally, with a plan to obviously roll out screening nationwide. So are we ready for the increase in thoracic surgeries? What can we do? Because we also saw the time from referral to surgery being way higher than what we would consider to be acceptable. What's the solution, Doug?
Well, I think that's a great question, because we know there's a lot of challenge there, isn't there? The data that you showed shows that we just need to do better on waiting times, don't we? The background before screening ever started, of course, was that we've been seeing about a 5% year-on-year increase in activity for at least a decade now in thoracic surgery, and that probably reflects a lot of things: a bit more investment, but also that big move towards minimal access surgery, which has allowed more people to come through surgery. And then more recent innovations, particularly the new trials on sublobar excision for early stage lung cancer, so we can offer good quality oncological surgery without taking whole lobes away now. Robotics is bringing in a new option there, particularly for those smaller resections that are technically a bit trickier. And then there's things like enhanced recovery that are allowing more patients to come through. So we've got a challenge there. And even outside lung cancer, other things we're doing, we're probably under providing things like surgery for severe emphysema. Thoracic surgery is certainly getting bigger, and I think and you can see that in your data and in the society's data, and it's done that consistently. We're being helped a little bit, I suppose, by attracting more people in. It's becoming there's a lot of innovation, especially, so it's an attractive and it's a fun thing to enter. There are some specific initiatives for about 2 or 3 years now There's been an ST4 entry route, taking people who've maybe been in cardiothoracic surgery but haven't quite got into national selection at stage at ST1, so they can come in a bit faster if they've already got some general experience and trained specifically as a thoracic surgeon. We continue to attract people coming in from abroad, and then I guess on top of that expansion in our workforce, and we've got to bear in mind, of course, screening is bringing in lots of new disease. We're a bit unlike, for example, colorectal surgery, where a lot of people were already having surgery, early stage disease, late stage disease at some point in their pathway before they started screening. But before we started screening, most people did not have an operation. So now we've got all these people who would have been treated non-surgically coming in. So we have got to think about squeezing our resources a little bit. We're definitely, I know Lauren and I are working in Bristol. We're doing an awful lot of weekend operating now. We're operating now at 8 o'clock in the evening. We're trying to use that crucial resource of theatre as much as we possibly can. So it's going to be a lot of different things. I think we are doing a lot, but you and the team and the data challenge us that we need to do more faster.
Thanks, Doug. I have another challenging question for John about our SACT rates. So we saw that our treatment rates for SACT is down at 62%. So this is for patients with advanced disease and good performance status. John, what's going on here, and what can we do about it?
I think it's probably multifactorial, Neil. I think that they present with a good performance status, but as we're seeing, the pressure on resources within centres is such that the time it's taking for patients to get through the sort of treatment pathway is taking longer. And I fear that these patients with advanced disease are therefore susceptible to their performance status slipping, and perhaps slipping below that sort of threshold for suitability for SACT at the time it's eventually ready to be administered. I think ultimately we need to obviously improve things. So there's an unmet need. We need to improve SACT uptake. I think we need to focus efforts as we have done in the past, but perhaps double down on earlier diagnosis, shortening that pathway to treatment, standardizing molecular testing. We've seen early data in this State of the Nation report on molecular testing from some years ago. And I think as that data matures and we see more contemporaneous data, I'm hoping it shows that things are improving, because it's imperative. If we don't have the data at our fingertips when we're making treatment decisions, clearly there's patients who may lose that opportunity for therapies. I think all of the team have highlighted the importance of data quality. I think real-time data monitoring can obviously drive quality improvements within our centres. And I think through a coordinated approach to all of these different aspects, we should hopefully begin to see an equality sort of focused approach to care that really is needed, so that eligible advanced patients can be treated in a timely and effective manner within our oncology centres. So I think there's quite a bit of work to do, Neil.
Thank you very much, John. And we do see a lot of variability across the country, don't we, in that particular metric, which does suggest that higher rates can be delivered. So I think some work to be done there. Two really quick questions. One for Lauren, if I can, which one of our audience members wants to know about: how do we highlight cases who have had neoadjuvant or perioperative IO?
Okay, that's a really good question. It's definitely something that's becoming more and more important. It's becoming more and more common. So that's not something that we would be able to pick up at the moment in the quarterly reporting, but it is something we can pick up in the State of the Nation. So when we look back at the whole year, and the way that we can detect it is we will know if patients have had surgery, and we also have access to the SAC database, so we'll know if patients have have had sacked in leading up to the surgery or afterwards. So we'll know if they've had neoadjuvant or adjuvant sacked. And there's quite a specific regime for the neoadjuvant lung cancers. So we can get that from the SAC database as well. It's something that's obviously rapidly changing quite a lot, this whole area of lung cancer. So we have to just stay up to date as we possibly can on it. But it is on a sort of on a quarterly basis, we might not get that because patients might still be going through that pathway. But for the State of the Nations, where we get to look back at a whole year worth of diagnoses, that's something we should be able to pick up.
Fantastic. So we should be able to report on that hopefully in the next State of the Nation report. And then really quickly, David, before I can ask you this question, does the NLCA or perhaps any audit within NatCan, does it have the ability to enforce trusts to improve?
The short answer is no. What we do have is links to other organisations so for example, the CQC, the regulator, we have a very close relationship with NHS England policy team, and they have links into, of course, the Cancer Alliances. And just to pick up, we are working across a number of audits with GIRFT, so they take our data and go into and use that when they go for visits. So we don't really have any enforcement, but we try and link into those that do.
That's fantastic. Thank you. Can I thank everyone who's been watching, also particularly my colleagues at the National Lung Cancer Audit team. Thank you also for your time and expertise this evening. Once again, thanks to First Sight Media and also BTOG as well for allowing us to host this webinar. And I just point out to you the next webinar, if you're not able to make it to Chicago, then please do tune in to the ASCO 2025 update, which will be on Monday, the 16th of June at 6 p.m. That's definitely an event not to be missed. Thank you very much again to everybody, and have a good evening.